2021 annual meeting in acute lymphoblastic leukemia. This program is supported by an independent medical education grant from Jazz Pharmaceuticals. Before we start, please take a moment to let us know who you are and answer the pre-polls in the tweets below. Tweets also include details regarding how to obtain your free CME credit. Be sure to watch our handles for additional ALL CME programming, as this program is a 6-part series, and follow at Bonum CE for more CME certified programs on Twitter. I am Dr. Lori Muffly from Stanford University, and I am joined today by my colleague, Dr. Marlise Luskin from the Dana-Farber Cancer Institute.
Hi, my name is Dr. Marlise Luskin. I'm an assistant professor of medicine at Harvard Medical School and a physician in the adult leukemia group at Dana-Farber Cancer Institute in Boston.
Our disclosures are shown on your screen. Upon completion of this educational activity, participants should be able to review recently presented clinical trial data in older adults with treatment-naive, Philadelphia chromosome-negative acute lymphoblastic leukemia.
Intensive combination chemotherapy is the standard of care for adults with ALL. However, older adults with ALL, defined as approximately over age 60 or 65 years, have been difficult to treat with standard chemotherapy, and their 3-year overall survival rate is estimated to be only approximately 10 to 20%, with high rates of induction and treatment-related mortality. Reduction of chemotherapy dose intensity in order to reduce toxicity has not improved survival, and thus targeted therapies are being evaluated in first-line therapy for ALL in older adults in order to improve outcomes. So we will review 3 recent data releases for older adults with ALL. The first 2 studies, EWALL-INO and the initial 1 study, evaluate the use of inotuzumab ozogamicin in induction therapy. We will review these trials together so you can see both the similarities and differences between these 2 studies. So this is the EWALL-INO study. The goal of this phase 2 single-arm study was to assess the activity and safety of lower doses of inotuzumab in combination with low-intensity chemotherapy as frontline therapy for older adults with CD22 positive Philadelphia chromosome-negative ALL. The study enrolled adults aged 55 and older with CD22 positive disease, defined as greater than 20% of the blast being positive, that were treatment naive and Philadelphia chromosome negative. They were negative for CNS involvement at diagnosis and did not have any prior chronic liver disease, as well as known activity with HIV or hepatitis B and C. The primary endpoint was survival at 1 year, and secondary endpoints were complete remission rate, death during induction, leukemia-free survival, and the impact of MRD and oncogenetics on outcomes. The goal of the phase 2 initial 1 study was very similar, except that this study evaluated single-agent inotuzumab monotherapy as induction therapy for older adults with CD22 positive Ph-negative ALL. This study enrolled patients 56 and older, also with CD22 positive Philadelphia chromosome-negative ALL that were treatment naive. Had very similar enrollment criteria. Although they did not have CNS involvement as an exclusion criteria, these patients were permitted to enroll in the study. Here, the endpoint was EFS at 1 year compared to OS at 1 year. And secondary endpoints are listed here, including CR, death during induction, death during remission during subsequent follow-up, relapse-free survival, overall survival, MRD response, and frequency of molecular relapse. Here is the treatment schema for the EWALL-INO shown above the treatment schema for the initial 1 study, and you can see the similarity in differences. Again, the main treatment differences were there in the EWALL-INO study. Inotuzumab was administered in combination with low-dose chemotherapy, followed by a chemotherapy-based consolidation, whereas the initial 1 study, single-agent inotuzumab was administered, followed by chemotherapy. The other notable difference was that in the EWALL-INO study, inotuzumab was given during consolidation, there in the blue, during consolidation 1 and consolidation 4, whereas in initial 1, inotuzumab was only given during the initial treatment. The other difference would be that there was asparaginase included in the initial 1 study. While you can see that these were both phase 2 studies and they were single-arm studies that didn't compare 2 different regimens, they were single-arm. and they were relatively small numbers of patients. You can see compared to historical experience with this populations, the CR rate was very high in both studies, and there was a high rate of MRD negativity after course 2 or 3 of induction for those patients who were evaluable. The 1-year survival was also very high, 78% in the EWALL-INO study and 91% in the initial one study. Here we can see longer follow-up. On the left, relapse-free survival for the EWALL-INO study, which was 76% at 1 year, and event-free survival in the initial one study there on the right, which was at least 80% at 1 year. With respect to toxicity that were presented, we don't have lots of details from the ASH presentation, but notably the rates of grade 3 and 4 hepatotoxicity was relatively low, below 10%, as reported here in the EWALL-INO study, and the rate of SOS, or VOD as it's sometimes known, was 3%. In the initial one study, the rates reported were even less. There was also low rates of induction mortality, 3.3% in the EWALL-INO study, and none reported in the initial one study. There were deaths reported during follow-up in the EWALL-INO study, and these were noted to be during infection. So in conclusion, what can we take away between these two studies? We can take away that inotuzumab is an active drug as induction therapy, whether given as monotherapy, as it was done in the initial one study, or in combination with low-intensity chemotherapy, as was done in the EWALL-INO study. And this is an active therapy for older adults with Ph-negative, CD22 positive B-ALL, with high rates of remission, and those remissions are generally MRD negative. The EFS and OS reported out at 1 year is promising, though still obviously relatively short. These results are encouraging for further investigation of inotuzumab as an induction agent in prospective and comparative trials.
Okay, now let's take a look at a recent publication in April of 2022, just published in the Journal of Clinical Oncology. This is the SWOG 1318 phase 2 clinical trial of blinatumomab followed by POMP maintenance in older patients with newly diagnosed Philadelphia chromosome negative B-cell ALL. You can see the key inclusion criteria, exclusion criteria, and endpoints of this study conducted by SWOG. As you can see, because this is a trial examining blinatumomab, the requirement for CD22 positivity is not necessary as opposed to the previous clinical trials that were presented. This study enrolled slightly older adults over age 65 with treatment-naive Ph-negative ALL. Patients were excluded with CNS involvement. The primary outcome was overall survival at 3 years, and it was noted in the statistical analysis that the study would end for futility if a true 3-year overall survival rate of 10% or less was witnessed. So that was the null hypothesis. Secondary outcomes included complete response, death during induction and toxicity, disease-free survival, and MRD response. The schema for SWOG 1318 is shown here. Patients received blinatumomab as induction for 1 cycle with a reinduction with blinatumomab planned if CR was not achieved after the first cycle. Upon CR, patients then received 3 cycles of blinatumomab as post-remission consolidation. This was followed by 18 months of maintenance with standard POMP, prednisone, vincristine, 6-MP, and methotrexate. During induction therapy, blinatumomab was administered at a starting dose of 9 micrograms daily for days 1 through 7 with a ramp up to 28 micrograms starting on day 8. For reinduction and consolidation, blinatumomab was administered at a dose of 28 micrograms continuously as per standard. 8 doses of intrathecal methotrexate were given as CNS prophylaxis. So here you can see the patients enrolled, and relative to the previous 2 studies that were presented by Dr. Luskin and presented at ASH, this phase 2 study was single arm with blinatumomab. As you can see, 31 patients were enrolled. The complete response to blinatumomab monotherapy was 66%, and MRD at end of induction 2 was 92% in 23 of the 31 evaluable patients. The 3-year overall survival was reported to be 34% with the confidence interval as shown. Of note, MRD was assessed centrally on this study by 8-color flow cytometry, pre-treatment on day 35 of induction 1 and day 35 of reinduction, and MRD negativity was defined as less than 0.01% on the basis of the sensitivity of the flow cytometry used. Also reported, again shown here, the results of the SWOG 1318 study, a very descriptive cross-comparison. The two INO studies previously presented, you can see the disease-free survival of SWOG 1318 was 37%. You can see the survival curves up to the 3-year endpoint, again, just for rough cross-comparison to the inotuzumab studies. The blinatumomab with POMP maintenance was very well tolerated. 29 patients were reported for toxicity. There was only one grade 3/4 CRS event, one grade 3/4 neurotoxicity event due to blinatumomab, and one patient died during induction of toxicity. In conclusion, the SWOG 1318 study of blinatumomab followed by POMP maintenance in older adults with newly diagnosed Ph-negative B-cell ALL demonstrated high relative response rates relative to historical controls in this population. Perhaps the disease-free survival and overall survival at 3 years were slightly lower than one had hoped, but further investigation of frontline blinatumomab in older adults, particularly in combination possibly with inotuzumab, is warranted based on these results.
Well, thank you, Dr. Muffly, for presenting that abstract. We are seeing, as these abstracts that I presented and that you presented, really promising early data regarding targeted and novel therapies in older adults with ALL, a population that really has been in need of new treatments as they have poorly tolerated and not responded well to our standard approaches. How is this data being incorporated into the clinic, and how does this data help you in terms of your management of patients?
Thank you for the question. I think that it's difficult to know exactly how novel agents are being incorporated currently frontline in older adults, partly because this is a rare disease, it's a rare population, and getting at those data is quite difficult. We also know that treatment patterns in ALL vary quite substantially depending on where the patients are treated and seen. And so I think in our region, there's certainly been a fairly big uptake in the mini hyper-CVAD with inotuzumab as frontline therapy in older adults. We've also had several of the cooperative group trials open with blinatumomab and inotuzumab given it in combination subsequently. There has been uptake in terms of incorporation of venetoclax into these regimens. And so I think that we are going to see more and more of the use of novel agents in the frontline setting in ALL, not just in clinical trials, but in clinical practice. And it would be really great if we could somehow systematically study what's being used across the country to get at those data.
Yeah, I agree. I think this is really exciting data, and I think it really just also emphasizes how important it is to enroll patients in clinical trials and for us to complete these studies to really get that data, understand these regimens, and know which one is best to be applied to which patients and which setting. Thank you so much for joining us today. Please make sure to claim your CME credits by completing the post-test and evaluation at the link on the screen. And make sure to follow @Bonum CE on Twitter to stay tuned for more ALL content.